Hi, welcome to Dental XP and to this webinar Wednesday. My name is Miguel Stanley. I'm a dental surgeon from Lisbon, Portugal, and I'm proud to be part of this XP family now for a many number of years, and it's truly incredible to see how this platform has just taken off globally. And I'm very privileged to lecture all around the world and to see XP being a bigger and bigger part of education all over the globe, not just in implant dentistry, but in cosmetic dentistry and all types of day-to-day clinical work. And it's just wonderful to see how so many dentists who can't afford to travel to distant parts of the world to attend lectures or seminars or courses, to be able to very simply in the comfort of their home see outstanding lectures. I'd like to give a big thanks to the entire team in Atlanta for helping me here today, and also my team here at White Clinic for setting up the this lecture for me. So before we start, I work in quite a large practice. It's an interdisciplinary team that we have here. I have some members on my team for almost 14 years. I work with the same lab for over 17 years. I have an orthodontist, a perio, endodontist, two other implant surgeons. We have prosthodontists, cosmetic dentists, pediatrician dentists. So we're quite a multidisciplinary team, and my side of this practice is focusing on complex oral rehabilitation. So we like to look at the mouth as a whole, and for those of you that have been following my work over the years, we actually have, as you can see here on the top, the no half smiles philosophy, which is full mouth rehabilitation as a philosophy and as a business model, and we like to call that life-changing dentistry. So let's get started. The title that I was challenged to discuss today was Tipping the Needle in Implant Dentistry, and I'll get straight into it. As we know, Dr. Brannemark, who pioneered implant dentistry in Sweden all those years ago, he came to revolutionize dentistry as we know it, because pretty much before him, if you were missing a tooth, the only way we could rehabilitate was with a partial denture or removable denture or bridge work of any kind. So implant dentistry really did come to help, as we know now, tens of millions of people around the world to be able to chew. And of course, to have your teeth back, it's not just about function, it's also about aesthetics and dignity and, getting your humanity back, because we all know what it must feel like to miss a tooth. I say that out of experience, because this tooth here is an implant, and I know how I felt when I lost that tooth. So what is all the fuss about in implant rehabilitation? So if we go back to 1965, and of course through the first decade of implant dentistry, with this classic implant that you see here on the screen, which was the Mark III 375, and I can say that I myself placed many of those implants, and you can see here we have an implant, two of these implants placed in 2001, and we have a follow-up in 2008, 2010, and here in 2011, and you can see what was usually described as a classic bone loss to the first thread. These type of implants were very, very stable and long term. There was always a little bit of bone loss to the first thread, and you can also see here that it's not just about implant dentistry. You can see the adjacent premolar here that had a little lesion due to a bad endodontic treatment. And in 2015, you can see a very long-term stable treatment. This was actually done with MTA by Dr. Carlos Moraes on our team. So before we do get into this lecture on implant dentistry, here at White Clinic, we're huge advocates of endodontics and to try and save natural teeth as much as possible. I think that's a strong moral compass that most dentists should follow, no matter how much you love doing implant dentistry. But in this slide, what I intend to show is that 15 years ago, here I am placing this simple implant that was designed almost in the 60s, and even today it's still very stable in the mouth, and that patient has had an incredible longevity with this, and because he does his follow-ups, has a good oral hygiene, everything indicates that he can have another 15 years with this implant in his mouth, hopefully. So what has all the stress been about in implant dentistry over the past decade? And I've been an implant surgeon for 16 years now, and I've been around to lectures all over the globe, and seen so many amazing new advances in implant dentistry that there's been a lot of discussions over the past 15 years. And let's talk a few of them, not by order, but new things, not so new, but guided bone regeneration, the incredible advances in guided bone regeneration, the importance of having keratinized soft tissue around the implant, osseointegration, which was of course the very first big discussion around implant dentistry, the implant surface. We've seen so many different type of surfaces appearing over time, and even now with the new fully zirconia implants. The use of piezo surgery to prepare the site, how to enhance soft tissue before, during, or after implant placement, the shape of the implant, cylindrical implants, tooth-shaped implants. These things, of course, have also been a huge source of discussion. Flapless surgery versus full flap surgery, delayed versus immediate placement, immediate loading versus delayed loading, the type of connection, internal, external. We have seen so many amazing lectures and so much science come out of all of these debates over the years that sometimes for dentists starting out in the field of implant dentistry, it can sometimes be overwhelming. And I'm very lucky to have been a part of all of these discussions as I grew as an implant dentist myself. It's also important to understand here, I don't just place implants, I also do the restorative side. So we actually plan backwards. So we'll start with the end game, how we want the smile to look like, soft tissue, where we want the soft tissue, and then we plan things backwards. I think it's very important to have that vision. And it's not just about placing implants, it's about the overall end results. So let's clarify this a little bit. So back in the 70s, the biggest discussion, and even in the early part of the 80s, the biggest discussion in implant dentistry, the only big stress was very simply osseointegration. Do these things work? And I sometimes say, we have a Portuguese, I'm from Portugal, and we have a Portuguese author who actually won a Nobel Prize. His name was José Saramago, and he wrote a book called The Essay on Blindness. And in this essay, he expands a little bit on what it would be like if everybody in the world went blind. And one of the things about that is aesthetics wouldn't matter. The only thing that would matter is, do things work? Will things last? Function. So of course, when it comes to osseointegration, we know implants work. We know that they integrate no matter what shape or size. Most modern implants on the market today will osseointegrate if placed under the correct guidelines. However, you might not always get aesthetics. And I'm sure that back in the 70s, just if you could place implants and give the patients a functional bridge or denture or whatever, that was already enough. That extra added anchorage, that extra added support was enough. However, as time progresses, we know that patients are getting more demanding. Aesthetics is the big word. I mean, aesthetic implant dentistry, the actual usage of that terminology is very recent. And, to be able to now place an implant already planning for where the soft tissue has to be, and as my good friend David Garber, also one of the founders of XP, likes to say tissue is the issue, but bone sets the tone. And I'm sure everybody around the world knows that famous sentence, that we place an implant and we try and preserve as much bone as possible, but always planning for how much soft tissue we'll have at the end, because, you know, to get a tooth over an ossigated implant is easy, but to get a tooth over an ossigated implant with perfect soft tissue and perfect papilla, this is the challenge. And nowadays, if you're aware of all the variations in the literature and clinical research, the truth is that you have to apply all of your scientific knowledge to each case, which makes it that the more you know, the harder it becomes to make a decision. And I can safely say that with all the technology we have in this clinic, with all the different designs and surfaces, and the more studies that you read, every single case is case sensitive. And it makes it really hard to make this instant algorithm while you are operating or while you are planning your surgery to get an optimal outcome. So the aim of this little presentation, this webinar here, is to present to you a few cases of things that I never would have done 5-10 years ago with implant dentistry. And as the title suggests, tipping the needle is doing a lot more with what you have. So I'm fortunate enough to work with some of the top guys in the world, to be very active online, to be very active in the conference circuit. And I'm always taking little bits home with me. And I'm going to share a case here with a dear friend of mine who lives in London, and she flew in with a fistula on her central, tooth number 11 in Europe, which would be probably, I believe, number 8 in the American denomination. And of course she had some crooked teeth, she had a diastema she wasn't happy about, but these are minor things. So as we can see here, she has a fistula. Now, of course, we decided straight for the root canal, and Dr. Kairos performed the root canal treatment with MTA under the gold standard guidelines. And when he finished this treatment, he said, you know, something's not right here. And we didn't catch it on the CBCT, and we couldn't catch it in the x-ray, but, you know, of course, 10 years of clinical experience, he knew something was off. And we said, well, look, we can't take any risks here. So we went back to the CBCT, and we had known that this root was positioned against the labial and cortical plate, but we said, I think it's best that we do an exploratory probing here. So we raised an aesthetic buccal flap, as described by Murray Steigman and Homley Wang. This flap design has actually really saved my life so many times. And for those of you that don't know Professor Steigman, he's one of the leading perio implant surgeons out there, based in Germany. And the first time I saw this design, I understood that it allows clinicians to correct apical and buccal fenestration defects while maintaining the supraosseous soft tissue around the aesthetic zone, which makes it quite interesting. So we raised this flap, and lo and behold, we found that there was a root fracture that we couldn't locate, and obviously the reason for the problem. And as a result of this, we also had the loss of the buccal plate, and the only indication here was for extraction. So we extracted the tooth atraumatically, and of course, here we know that the resorbative defect is always facing the fracture line, so it's a longitudinal fracture here, and you can see the size of the defect was actually quite large. Now, with what I was trained to do 10 years ago, 15 years ago, in a case like this, I probably would have just grafted, placed a collagen membrane, done a soft tissue plug at to close the socket, but almost never would I have placed an immediate implant, 10 years ago. But with the new designs of implants, I feel more and more comfortable to go into immediate placement, despite this being quite a large defect. So I think that one of the most important things for me as an implant surgeon is to protect myself against failure. So knowing that there's a lot of new, or some of them not so new, technologies out there, I think it's super important for us to work with them and to incorporate them in our day-to-day lives. So here, I want to talk a little bit about Dr. Joseph Shukrun platelet-rich fibrin, or PRF. This is already a second-generation platelet concentrate, and he lectures all around the world. Dr. Joseph Shukrun, Professor Joseph Shukrun from Nice, he is truly a visionary when it comes to this technology, and I really urge all of you to try and catch a lecture of his anywhere you can around the world. So the clinical applications of PRF highlight an accelerated tissue cicatrization due to the development of effective neovascularization, accelerated wound closing with fast cicatricial tissue remodeling, and nearly total absence of infectious events. This is pretty much what we get when we use this technology. So it's quite simple. With some basic training, you can learn how to use this technology. It requires learning how to remove some blood, and there's a special type of centrifuge. The machine is incredibly simple to use. And we mix that in here with Genos, which is made by a company called Osteobiol from Italy. We use a lot of different types of regeneration materials, Geishlich, BioOS, also a great product. Been using that for 15 years now, and now we're doing some comparative studies with Osteobiol and getting some really good results as well due to the higher concentration of collagen. So as you can see, when we mix the PRF with the bone, it actually creates something Dr. Shukrun likes to call sticky bone, and it's a lot easier to use. So we're going to pack that into the socket in excess. As you can see here, it's sticking already out of the defect, and how the acetabulbar flap maintains that soft tissue in the aesthetic zone. So that's all mixed into place and packed into place, and now we're going to place our fixture, our implant. This is a 4mm diameter implant and 15mm in length. This is a Megagen Any Ridge implant. It's a wonderful design for immediate placement following extraction. Here we have the implant placed in optimum positionment, and most of those threads have engaged with the mesial and distal bone, and of course with the palatal bone, because of course that whole buccal plate is just this sticky bone. We place that implant at an optimal level, because I'm going to apply platform switching techniques, and I'm going to place my implant subcrestal. So with this type of implant, we want to put the implant subcrestal as opposed to the original implant philosophy, which to do that at a bone level. And still today, many implant designs do require you to place those implants at bone level. So for those of you that are starting out, make sure that the implant system you are using is specific for subcrestal placement, bone level placement, or even some of them you have to leave out of the bone for soft tissue management. Now, here we are placing the APRF membrane, and you can see it's A stands for advanced, so it's an advanced PRF membrane, described again by Joseph Shukrun, and we place that over the entire defect, which will help with regeneration on so many different levels. And just to be safe, on top of that, we place a BioGuide collagen resorbable membrane, just described in classic gold standard guided bone regeneration techniques. And for those of you that can see as well, we did a little surgery here using our electric bisturi on the frenum, just to release the frenum a little bit, because she had quite a low insertion on her frenum, to kind of also release any tension from her lip, because one of the secrets of surgery, I always say, is the suture. So that frenum being so close to the defect, I was a bit scared that it could pull on it. So we released the entire frenum prior to closing the wound. So here we've done our suture. We closed everything with nylon, no tension, so tension-free suture. And we're now going to place a little bit of soft tissue that I harvested from the tuberosity using a tissue punch, actually from the MegaGen surgical kit. So we just got that tissue punch. We went to the back of the tuberosity under local anesthetic, and of course we've removed the epithelium to help the integration of this little bit of soft tissue. But before we do all of that, we're going to measure the implant stability quotient, so the ISQ. This is a specific pin, which I like to talk into in between 5 to 10 newtons. And the Ostel technology, this actually is also made by MegaGen, and it's a really cool little digital device that helps us to read. So with that, we know that if we have a measurement of under 65, that means we have a low stability and we shouldn't really think about doing immediate loading. If we have over 65 to 70, then we can actually load that implant with a crown. If we have over 70, that's a high stability, we can actually load that in function. And once again, for almost a decade, it was pretty much my hand or my torque machine that would tell me how stable an implant was. So if I had a torque of 40 or 45, I was like, okay, this implant's highly stable. So now I'm not just using the torque of insertion, but also 100% of the times when I'm doing loading, I use the ISQ. You have to do this because the science is out there, and you can't just go out there and trust your instincts anymore. You have to trust the science. So a wonderful tool, not just for you, but also for your patients to really see that you are using the science in their benefit and also in your benefit. So in a case like this, if I had less than 65, I would still place the crown, but I would definitely splint and take everything out of occlusion and put my patient on a soft diet for about 7 to 8 weeks. Or I would take the implant out and change a 4mm fixture for a 4.5, and usually that would raise the ISQ measurement. So sometimes you have to have the courage to take out that implant, replace it for a wider one. Little trick here for those of you watching. So what ISQ is, it uses resonance frequency analysis to measure the stability of the bone. An incredible tool for anybody venturing into immediate loading over implants. Now, it's time for us to go for the aesthetic immediate temporization. So, once again, when I started out placing implants, placing in the aesthetic zone an immediate crown, I mean, this would be crazy. I was trained to cover everything up, wait 6 months, then open up, and then do the soft tissue modulation with temporary structures. But that would take several interventions over a long period of time. And the truth is that nowadays you will lose your patients to your competition if you cannot give an immediate crown on the day of the surgery. Why? Because they know somebody who's done it, they know it's possible, the internet, the information is out there. Unfortunately for many of us, a lot of that information is misleading because this is not always possible. And I mean, I've been doing this for many, many years, and I'm still always scared when I do this. But once again, I am building this case based on the science, based on the evidence, and based on the technology. So here we're going to be using this is called a fuse abutment. It's a specifically designed PMMA temporary abutment that actually has the Cone-Morse internal hex connection, so very good connection. You have different lengths and different widths, and it actually comes with a finishing line, and you'll see that in a bit. But I wanted to show you also here the soft tissue that I've just wedged in place here to give a little bit of extra volume. And here we have that fuse abutment in place, and now we're almost dealing with this as if it was a natural tooth. So we have here, of course, some gap. Of course, Dennis Tarnow described in his seminal paper that the jumping distance, this would close. But if we follow, of course, the work of Nick Elian and a lot of other wonderful surgeons out there, and my own personal opinion is to pack that with bone as much as possible to not take any risks in this case. So we packed a lot of bone around that space, not leaving anything to chance. And here we made a provisional crown using structure 3, which is the nanoparticulated bisacryl from Voco. Everything nicely polished. Of course, you have to unscrew that and polish it and create some nice contour in there to not over compress the soft tissue. And we, just to be 100% certain, we fused that to the adjacent teeth. So this is an immediate post-op photograph and an immediate post-op x-ray of the surgery. And as you can see, like I said, this is the level of that subcrestal implant placement. Here is the fuse abutment, and you can see the transparency of the structure of the bisacryl in place. There's no excesses, and you can see how I've packed bone, as much bone as I can, to fill all the remaining space in that socket. Now this patient, as I said, lives in London, so she actually left the country on the same day, and about a week later she left us this video.
Okay, let's see if we can do a little video. So generally, as you can maybe see, the face is sort of more or less back to normal. There's still this bit here that feels really, really hard, but it feels like it's getting a little bit better every day. I'm still a bit, as you see, when I'm smiling. That's just, and that is sort of how it is looking at the moment.
So of course, we were very relaxed and relieved to see that after 1 week, her healing process was going well, and 3 months later, she flew back to Portugal, and this is how her healing process went. We had a colleague in London remove her stitches. A big thank you to my friend in London who did that. And so here you can also see the importance of having released the frenum, because I believe that that was very important to get that anchorage away so that there was no tension on the suture. Very, very important. And Professor Shukran talks a lot about this in his surgeries, about the Momoto study, about the effect of compression and tension on the healing process. So here we can see maintenance of buccal volume following 3 months after the surgery, and a CBCT at 3 months where you can see all of that lovely bone, an optimal placement of this implant, and we do have a osteo-integrated implant happening here. So now we're confident that we can go into our impression. Once again, tipping the needle in implant dentistry. I feel more and more confident to go straight into a definitive impression following 3 months, because I know right now that this soft tissue is incredibly stable. I usually would have waited 6 months, but now, due to the science that is out there around this implant, the science that is out there with the PRF, and my own clinical experience, I am more and more confident that we can reduce the times that were standardized. Of course, if it's in the posterior region, I don't mind waiting. It's out of the aesthetic zone. But with an active female patient like this, we want to just get this case over and done with. So now you can see this beautiful gingival modulation done by the fused abutment. And we're now going to take an open tray impression. We've prepped the adjacent teeth as well, because we are going to do some extra ceramic work to own that smile, because remember, she wanted to close her diastema, so we have to do work on the adjacent central and also on the laterals, because she didn't want to lose her identity, but she wanted a new smile. So we did some freehand smile design at the beginning of the surgery, which she was very happy to do. But again, had she just wanted the single tooth, that would have been okay. But once it comes time to get the final smile in place, it's very important to ask your patient, say, listen, you know, you do have diastema, you do have the crooked teeth. Now's the time that you have to decide if you want to get everything done. And she said, please, let's just go ahead. I'm so confident with the way things are going. So here we have an impression coping. It's got a hexagon. Always make sure you take an x-ray to make sure that this is in place. And then we inject some flowable composite very, very quickly, again, because this soft tissue will collapse quite fast to maintain all of that beautiful work that the temporary abutment has done over the past 3 months. We send that off to the lab. The lab starts designing our crowns. We're going to have a zirconia core, then with stratified Evoclar ceramic over that. Here's some of the lab work. And then these are the final crowns. And here is at the moment of cementation. So we have a customized zirconia abutment for the implant. And again, look at all that soft tissue. It's beautiful soft tissue. And here we have the adaptation of the crown, the zirconia abutment, and look at the beautiful platform switching technique that was performed here, which this system allows. And we're about 1 millimeter subcrestal here. There's no compression on the bone from the ceramic structure. And here we are cementing using a specific cement for zirconia crowns. Very important to remove excesses. I'm sure a lot of you are aware of the studies out there of how a lot of peri-implantitis or a lot of problems around implants surge as a result of cement that gets into the implant. So one of the advantages of placing your implants subcrestal is that you put your implant quite far away from the crown area where you'll be using cement. So that's one of the advantages of using the system of subcrestal implants. So this is an immediate post-op photograph, and this is her after about a month. And once again, she's incredibly happy with this. Now we know, as an evolution of Dr. Dennis Tarno's study of the contact point, the famous 5 millimeters between two adjacent teeth from the contact point to the crestal bone, you'll always have papilla. And then of course Team Atlanta went on to develop that study, and as you can see here in the chart, tooth to implant is 6.5, and we know that here we have a lot less than 6.5. We actually have only 4 millimeters. So we're very comfortable in trusting the science here that that papilla will be maintained. And again, because we placed an immediate implant, the maintenance of the supracrestal fibers and of all that bone is more predictable than had we done a delayed implant placement. So again, huge advantages of doing immediate placement and immediate extraction despite having such a huge defect. So in the concept of tipping the needle, something like this usually would have had a higher degree for cosmetic failure despite having been able to achieve osseointegration. So let's say in 2015, I would have done guided bone regeneration with, let's say, BioOs and BioGuide. My patient would have left with a partial denture or a Maryland bridge, and then 6 months later, I would have gone in, placed a Bronnemark implant, waited and covered it, waited 5 months, and then slowly started working. But the truth is that I always would have lost some of the buccal plate. I would have lost some vertical height there, and I never really was getting these results. So using the PRF, using the subcrestal implant, using the platform switching, using the aesthetic buccal flap, all of these little technologies described in the literature, trusting the science of our, the giants in dentistry, really help you make a series of calculations at the point of doing your surgeries that help you just relax a little bit, you know, and that's what I'm trying to talk about here, and I hope you can take some of these messages home. And that's what it's all about, is having a happy patient. She was going through some troubles in her life, and now she's just super happy, and we like to call this life-changing dentistry. We didn't change her smile. It had a low impact in her lifestyle because she had very few trips. She only had one surgery, and using state-of-the-art science and technology, we really get to deliver great results. And of course, I hope to keep you all posted. And for those of you that want to see follow-up cases, I mean, I'm happy to once a year post this case on Dental XP World, the Facebook forum that everybody uses on Facebook. So challenge me every now and again to show you follow-up CBCTs and x-rays and photographs of this case. So let's jump into a next case, which I believe also I wouldn't have been able to perform with the classic implant guidelines. So here we have a first molar in the second quadrant, so in the upper left quadrant, tooth number 26, and the patient came in referring pain when chewing and had a level 2 mobility of this tooth. And as you can see in the periapical x-ray, there's a large endoperio lesion there. So the only thing we could do was extraction. Now, sure, a lot of you are thinking right now that we can't really do much here, because if I even look at the size of that tooth, there's no interseptal bone. This is some of the softest bone in the maxilla. It's a huge defect, and usually the largest implants out there are 5.5, 6, sometimes 7 millimeters. Not very engaging. So right now, with the science and technology out there, you're probably thinking guided bone regeneration, with or without flap, collagen membrane, PRF, whatever. Let's wait 6 months, then go back in and place our implant, because that would be a lot more predictable and a lot safer. But once again, tipping the needle, how can we push the envelope? What can we do that allows our patients to go home with predictable and scientifically proven clinical results? So here we can see I raised the flap. We clean everything with piezo surgery. We're very fortunate to work with WH, an Austrian company that has this incredible piezo. It's called PiezoMed surgical tips. So a little rough down and burn. We clean up all that bone, getting out all the infectious tissue. We spend a lot of time cleaning the bone. So, you know, a lot of younger surgeons want to get in there and place the implant. But those of you that have been doing this for many years know that you've got to clean, clean, and clean. I spend more time cleaning than I do placing the implant. So there's another little snippet of information for you there. So, a little history behind this case. Professor Kwang Bung Park, the developer of the system, the AnyRidge system, I've been following him around the world, and he was showing this case of how he was actually doing vertical ridge augmentation following the tenting philosophy, using the implant as a tenting device. And again, the more you know, the more you can achieve. Yes, you do have to make more calculations in the beginning, but there's not a surgeon in the world that can say that if you go into a surgery, failure is not an option. So we plan for success, but have to prepare for failure. So my patient knew from the onset that this might fail, but I said, hey, if it works, you will save yourself 6 months, you'll save yourself 2 surgeries, and it's a win-win situation. And with the size of defect you have, I'm going to use this implant as a tenting device to support, which I'll show you in a few seconds, a titanium mesh that comes with the system. So what did I do? I placed my implant not in, a lot of surgeons, once they take out a tooth, a molar this size, they tend to place the implant angulated into the palatal socket where you have that bone, of course, to avoid the sinus. But that implant means it's at an angulated position. It's not in the ideal perpendicular to the pressures that later will be applied during chewing, or in the center of the socket, and that's quite difficult to do. Now, of course, I didn't have enough bone here, so what I did is I only used the first 3 threads of this implant. Due to its thread design, I actually get quite a lot of stability, and everybody knows that you can't bend the basic rule of implant dentistry, which is primary stability. You have to have primary stability of your implant, otherwise it will fail. So I torqued this implant in, and about 60% of the implant is literally sticking out of the bone. But what do I know? I know that I have just give me 1 second. I know that I have an X-Ped surface here. And that X-Ped surface, which is designed, it has a calcium ion treatment to an SLA surface. This is an incredibly active surface that helps the integration of the bone quite fast, and I've actually not really seen anything like it. And I mean, sometimes I place these implants, and for whatever reason we have to go back in there after a few weeks, behold, and have a look at these implants, and the integration is incredibly fast. So I know I've got this X-Ped surface, I know I've got PRF, I know that guided bone regeneration works. So we are mixing all of that in, and as you can see, there's a special abutment here which also uses the platform switching technique, and it's a special abutment which will support this titanium mesh. This is called an iGen. So I've packed all that beautiful bone in, mixed with the patient's own growth factors, and I'm going to use this implant as a tenting device. So this this abutment actually is about 2 millimeters tall. So in effect, I am placing my implant subcrestally by 2 millimeters. And then using the stabilizing device, which is this titanium mesh, I screw everything into place. Now on top of that, I'm going to close my defect with an advanced PRF membrane, so the APRF, which is harvested from the patient's own blood. So we've mixed the PRF with the bone to create sticky bone, to use this to create the bone volume, and now we've created a membrane to help close off the defect. And you can see it here placed underneath the titanium mesh. And we harvested enough blood to get quite a bit of this membrane, and as you can see here, we've placed that over everything, which will help in case there's any fenestration. It will help with faster healing, it will help with and it can be exposed in the mouth, so it will help with any kind of soft tissue defect that I might have. Imperatively here, the soft tissue, the suture has to be tension free, so it's very important to play with the patient's lip to make sure that the flap has got no tension in it. And here you can see the immediate post-op x-ray and the huge defect that goes all the way to the third or fourth thread, so the first 3 to 4 threads are torqued into that bone, and you can see everything is sutured nicely. And there's a suture here on the palate that you can see, which is a resorber suture. It's a polyglycolic type of suture, which is a monofilament, and it's resorbable, and I like to use that to do a very deep apical suture, which removes a lot of the tension from the top. And also, if you follow Professor Shukran's work, he's a wide advocate of this type of suture. So many recent studies have shown the interest and potential of white cells in the inflammatory cascade as a prominent action in the early days of stimulation of osteoprogenitor cells, and this is one of the advantages of the APRF membrane. Now, after 5 months, we took a CBCT, and as you can see here in the lower left side of the image, that there's a huge amount of bone, and you can see the titanium membrane now sticking out, and we've got a lot of keratinized tissue there, and we are now going to remove this iGen. I can honestly say that some of these come out even sooner than that, following 2 to 3 months. They don't always stay quietly there, but it's done its work because that bone is already in formation. We waited then another 2 months, so this is 5 months following the surgery, and you can see a wonderful amount of keratinized tissue around that healing abutment. Patient had good oral hygiene, followed the protocol, and we've removed that healing abutment. That's 5 months after the surgery, and I'm good to go now with my impression for my crown. And there we have the crown in place. We like a screw retained structure here. Some people prefer a customized abutment, but here we just we went and did a screw retained crown. And very important here that our lab respects the bone. So this crown actually does respect the platform switching philosophy and leaving our implant quite subcrestal. And again, in the philosophy of this tipping the needle, in respect to the title to this webinar, this is something that I couldn't even have dreamed of doing a few years ago. But using the new implant philosophy of quite deeply placed implants with these new surfaces, with the PRF, it's with titanium membranes, following the science. It really is getting incredibly exciting to do complex cases quite predictably. So here's another case of a patient who had some missing teeth. This is a cosmetic case and an implant case. So for those of you that like cosmetic dentistry as well, she had some severe bone loss and a high aesthetic demand. She's a young, active girl in society. This is how she came in with her smile. She had some old crowns in the anterior zone that she wasn't happy with, and she was missing teeth in the posterior region. And here we have her panoramic x-ray. She had some not so good root canal done on her molars and her centrals, and she had a huge cavity over here. Now, following my no half smiles philosophy, there's no way that we're not going to fix the entire equation. So we sat her down and we explained that it was incredibly important for her to look at her smile and her teeth as a whole. We explained that she had a very low sinus here, and that would create some difficulty to place those implants. And also here in the first quadrant, she had enough bone that would permit for a direct transcortical implant placement. But we did a treatment plan. This was entirely devised by the entire team. So we sat down and we said, okay, we need to redo the endos. We need to do some sinus grafting. We need to also then devise some crown work. So this is kind of what we had envisioned for her. So here you can see in the CBCT on the second quadrant that she's got very, very little bone and quite a large healthy sinus, and an absolute indication for a sinus lift. So first things first, the endodontic phase. Dr. Carlos Moraes, who's been our resident endodontist for a decade now, redid, of course, under gold standards. He uses a lot of technology as well to do these cases. So most of it's mechanical. He likes to use the ProTaper files. He's got the System B, but already a new advanced. It's not my field of expertise, but the guy's just extraordinary. And as you can see, these aren't easy endos to do. And as an implant dentist, I can say that I much prefer to save teeth than see them extracted. So here we now have the patient. She's already had her endo work done, and you can see how she's got that inflammation of the palate due to her removable dentures. And this is one of the main reasons why patients seek implant dentistry as well, is to get rid of that discomfort that must feel like. So now we're going to raise a full flap to expose the wall, the buccal wall of the sinus, and using piezo surgery, we are going to perform a lateral sinus lift. And again, we use the WH piezo med device. For those of you that are used to using burrs, again, this type of device, it takes a little bit longer, but it's a lot safer, really worth the investment here, because you can most times keep that membrane intact. So one of the advantages, of course, is that delicate bony structures can be cut easily and with great precision without the destruction of soft tissue, which you cannot guarantee with a diamond burr. So we've now raised that sinus wall. We've packed that with bone. Here we are using BioWash from Geishlich. Now, tipping the needle in implant dentistry. My training was that a case like this would be almost impossible to place implants simultaneous with this sinus lift. That you'd do the sinus lift, you'd wait 6 months, sometimes even more, and only then would you go back and place your implants. However, I'm feeling more and more confident following my clinical evidence and also understanding better the design of the implant system that I'm using, that I could go in and place my implant with immediate stability. So this AnyRidge implant really does allow for incredible stability only with a few threads. So I've actually used my osteotome to prepare the socket, and I'm going to place those 2 implants. And believe it or not, I have a 35, almost 40 Newton insertion torque. I'm not going to use the ISQ here because I'm not going to load them. I am going to submerge those implants. And of course, again, closing everything up with the APRF, the advanced PRF, platelet-rich fibrin, as described by Joseph Shukran. And here you can see a little bit about that technology and how it works. It's incredible how technology really is helping us speed up our surgeries and have a lot more predictable outcome. So of course we then place our crubber screw for total submersion. We place our PRF membrane, and it looks a bit messy here, but we know that that's going to accelerate our healing and improve the biology during the next few months. So now again, you can see my suture going quite deep for a deep apical suture using this Resorba suture. Everything is nicely closed, and of course tension free. Very important to mirror the lip to make sure that there's no tension. If there's any tension, go in with a laser or an electric bistoury or even a scalpel and release that tension. I can't stress how much importance we give to tension-free suture. And as you can see on the other side, we've just done a very simple tissue punch and a transcortical implant placement. And here you can see an immediate post-op panoramic x-ray. So you can see the great endo work from Dr. Kadluj, 1, 2, 3, 4, 5, and our transcortical sinus placement, and here following the sinus lift. We take our CBCT to prove that we've got a good volume of bone, and again, we're very happy. Optimal implant, optimal distance in between our implants, optimal distance from adjacent teeth. There's a lot of evidence, there's a lot of science, there's a lot of papers, even here on Dental XP, which will explain why those implants have the distance they have in between them and the distance between the teeth. I can't get into all of that science right now without this lecture getting too boring. And of course, once everything's healed, 6 months down the line, we prep our teeth, and in one impression, we do the whole mouth in one go. And here you can see on the day of placement, all those teeth placed, and the final panoramic x-ray, you can see we've got some nice zirconia structures there. And here on the bottom right, we did a bridge. So because the bone here wasn't optimal for implant placement, and we didn't see any contraindications for this, and our patient wanted full mouth rehabilitation. And so again, we applied all fields of dentistry here to give her what she wanted, and that was a confident, healthy, biologically sound smile that we hope she can carry into the next decade. Of course, a patient like this needs constant checkups, and for the first 2 years, we want them coming in every 3 months. Paranoia, I usually say, is one of the greatest assets of any implant surgeon. We talk about success, but it's very important to keep a good eye on potential failure. And I like to call this slow dentistry because we like to take our time to get these results with our patients. Now, we know that technology is changing the world, and here on the left, we can see an image of people waiting for the chariot, reading a newspaper, and nowadays smartphones, technology is really taken over the way that we do things, but people still think the same, and people still want the same things. And technology, it's it's not just a change, it's actually evolution, and we have to be able to evolve into the future. And for those of you that are resisting transiting to the digital technologies, you know, for those of you that don't think that your smartphone, I mean, I use this to communicate with my lab, with my doctors, even in the clinic. You know, we're always online, we're filming things, and it really does help us so much in our day-to-day practices. And it's making everything easier, faster, cheaper, and more predictable. So, of course, the scanners, the CBCT, the 3D printing, and the CAD/CAM technology, this is not new. It's been out for a long time. And I'm just going to show you a little bit of a case of how we are helping also tip the needle in implant dentistry. Now, a lot of you are familiar with the work of Dr. Christian Coachman and of the DSD, and a lot of you will think that the DSD is exclusively for designing veneers or crowns over natural teeth. Well, the truth is that it also has incredible applications in computer-guided surgery. So here we have a patient who comes in with a total denture, top and bottom, and we actually apply the DSD over her existing denture using the protocol developed by Dr. Coachman and his team. And unlike Chuck Norris, who would come out and shoot randomly at whatever, and of course always win, the sniper gets things done more precise. And I like this video. I usually get a few laughs out of that. Why? Because nowadays, for people who don't have a lot of experience in implant dentistry, and even for those that do, using the digital technologies to help us precisely place our implants truly is, it's not the future, it's actually present. So I strongly urge all of you out there that have been placing implants or that are learning to place implants to reach out, not just to whatever system, just learn how to incorporate the digital technologies into your life. Of course, it's very important that you know how to do it manually, so you can always control and know when to pull out, because not always is it 100% foolproof. So this is how the team planned this. So we emailed this to all of our information to the team in Madrid, and here's a speed up print screen, video screen of how that works. And there's a lot of technology, there's a lot of time that goes into superimposing the intraoral scan to the CBCT, to the photographs, so they can superimpose those three things and give you a realistic interpretation of what we are going to encounter on the day of the surgery. So our team, Dr. Filipa Braga, Dr. Beatriz Mota Jordão from my team, who are two junior dentists who do an incredible work, and I'd like to thank them very much, and Joana Pinto as well for helping me set up this lecture. They do most of this work. That then gets 3D printed, and using these industrial 3D printers, which even now you can do this chairside in your own practice if you own a 3D printer, we print these surgical guides. Now, not only do we print the surgical guides, but using the same technology, we can actually 3D print an immediate denture using the digital smile design technology. This is really, really cool stuff. So for those of you that thought that the DSD was just for cosmetic dentistry, it's also for cosmetically designed implant surgery. So facially integrated implant guided surgery. Really cool stuff. And these little pinholes that you have here are actually the same pinholes that will be used to support the surgical guide and the template. So the same hole for the three systems. So this will position your denture at the Fox plane and at the SPI curve and at the vertical dimension that you have planned virtually. So the first part of this is we actually place these fixation pin guides. So this is pretty much the same as her dentures, and we put those in the mouth, and we can then drill our pin guides, ideally with the correct vertical dimension of our patient, and then we place in our surgical guides here from the DSD lab. And once again, this is open system, so you can use this with any implant system that you want. Most systems out there today, like Implant and so on, they are open source, so meaning no matter what implant system you use, they are compatible. So here we are. This is a fully guided implant surgery. So the reason why we have those metal wireframes inside the guide, and that's why you can't really do a fully guided yet chairside, is because those pins will stabilize the drill, not letting it go wherever it wants. So that would be the difference between a partially guided and a fully guided surgery. So this is how stable it is in the mouth. You can see in the little video on the bottom left, it's pretty stable. And we're now going to go in, we just drill through the bone, we clean all the soft tissue. If you want, you can even thread the piezo surgery around there to activate the bone as well. And you place that implant right through the guide. Of course, it's very important that your surgical drill kit is specific for the guide, so that the actual implant, the STL file of the drill kit, is the same as the one that you have in your practice, because that's very important for depth and positioning of these implants. Now, I've placed my 4 implants at the top, I've placed my 4 implants in the bottom, and if we're going for immediately loaded, we have to measure the ISQ, as I mentioned before. So here's the little Mega ISQ device, which has a digital screen, which is pretty user friendly. We measured the ISQ of these implants, and anything, as you saw, as I mentioned previously, above 65, you're good to go with immediate loading. So we did the top and bottom. I would say it took me roughly 45 minutes to place 8 implants. So 4 on the top, 4 on the bottom. Why? Digital guided implant placement. And for somebody who's been placing implants for 16 years, I mean, a lot of this is counterintuitive. You feel a bit scared, but the truth is that you have to trust the science. So now we have our immediate provisional prosthesis. And we've even got here a study from 1997 from Dennis Torno showing that immediate loading of threaded implants at stage 1 surgery in edentulous arches. And he did 10 consecutive case reports with the 1 to 5 year data in the International Journal of Oral and Maxillofacial Implants. And we know that as long as they are fused together and the occlusion is good, that this is a very good way of loading your implants. So we just do an intraoral pickup with the acrylic. We pick that out, we polish everything, and we screw that into place. And this is an immediate photograph following the surgery. There's no blood, there's no suture. It's very, very rapid. It is technique sensitive, so there is a learning curve. However, for those of you that are starting out, you might want to have your lab tech in the room when you're doing this to help you. And remember, go slowly. There's no need to do it fast. What you have to do is you need to get it right. So here we have an immediate post-op x-ray of this. Now, big respect to Professor Paulo Malor, also here from Portugal, for his all-on-4 technique. Once again, I'm not very proficient in the all-on-4 philosophy, but the evidence out there to support this is huge. So this is one of the rare cases where we actually did an all-on-4, and this is what we actually got following our surgery. And we decided to go in and actually plan to actually see how much variation we had from the virtual to the real. And here we can actually see we have a superimpose. So the guys at the DSD lab were awesome, and they sat with us, and we managed to see how much variation we had following this surgery. And we had a 1.9 millimeter deviation of platform position. We had a, just give me 1 second there. We had a 2 millimeter deviation of apex position. And we had a 6-degree deviation of axis. Now that sounds like a lot, so we went back into the literature, and according to Testori in 2014, we weren't that far off his studies where he did the evaluation of accuracy and precision of a new guided surgery system at multi-center clinical study, and this was published in the Journal of Periodontics and Restorative Dentistry in 2014. So we were roughly about between 10 and 15% variation upwards of this. However, if we go back in time to 2007, Van Asch had almost half of that. So again, we are still at early stages with this system. I believe that very, very soon as the end of this year, we'll be reducing these margins of error down to almost a residual amount. So it's very important that you don't trust the digital guides 100%. It's incredibly important to be paranoid because there's no perfect system out there. I'm very excited to start working with the R2 gate system from Megagen. We'll be doing some cases this week, and I hope to be presenting some results in the next few months, which I hear is incredibly accurate due to the software that they've developed internally. But once again, for those of you venturing into the computer-guided surgery placement, make sure you double check, you triple check, and use as much redundancy in that as possible. But again, we have a happy patient with this technique and with this technology, and the science out there, the evidence out there corroborates everything that we did. So all I can say is, don't be a cowboy, trust the science. I showed you some pretty aggressive cases here, but all of them soundly fundamented on scientific evidence, a lot of clinical experience and technology. So if you are going to incorporate techniques and technologies into your day-to-day practice, make sure that they are soundly based in evidence. Make sure you speak to the people that designed them. I personally know Professor Shukrun is incredibly available all over the world to help people use his amazing PRF technology. Everybody at the Megagen system is incredibly open to help you understand the design of the implants. Osteobiol have a great team all around the world. Geishlich as well, if you want to use their biomaterials. Also Resorba the team at Voco, what can I say? They are incredibly present when it comes to helping young dentists and incredibly talented dentists around the world to understand how their composites and more importantly the structure product can really speed up the temporization, immediate temporization with long-lasting results. I mean, I've actually had structure temporaries in the mouth for almost a year in some cases. That's how good the product is. So, if you are tipping the needle in implant dentistry, take it easy, practice flow dentistry. I'd like to thank you all for being here today. I'd like to thank everybody at Dental XP, and there's some questions that you'd like to answer. Please email or ask me. Please email me at miguelstanley@white.pt. I'm also available on Dental XP as an expert. So see you all soon. Thank you for your time.